Welcome to The Explainer. Today, we're looking at the human body's absolute master control room, the hypothalamus and the pituitary gland. I mean, think of this system like the main server that keeps the entire human machinery running. It's regulating your growth, metabolism, stress responses, reproduction, the whole shebang. But what happens when that server crashes? Well, the consequences of hypopituitarism can be catastrophic. They can be hidden and, honestly, sometimes even deadly. So we're going to break down exactly how the system fails, the alarms it sets off, and the highly specific, non-negotiable protocol required to reboot it. Okay, let's dive right into this. Here is our roadmap for today. Act 1, system vulnerabilities, where we find the root causes. Act 2, the alarms, detailing the hormonal fallout. And Act 3, troubleshooting and the reboot.
Starting off with Act 1, system vulnerabilities, or the root causes.
To really understand the factory defects here, we first have to define what it is we're looking at. Hypopituitarism is simply the deficiency of one or more anterior pituitary hormones. Now, from an embryological standpoint, and this is super cool, the pituitary gland develops from a little structure called Rathke's pouch. During fetal development, it migrates right along the midline of the body. Because of the specific developmental path, any physical midline defects in a patient, like a cleft lip, a cleft palate, or even an absent corpus callosum in the brain, are massive red flags for pituitary dysgenesis. Basically, if the midline didn't form right, there's a good chance the pituitary didn't either.
Let's see how this builds when we look at the genetic code itself. Notice how specific genetic mutations systematically knock out exact combinations of hormones. It's like a giant puzzle. For example, a PROP1 mutation is actually the most common cause of familial combined pituitary hormone deficiency, and that typically results in a failure to hit puberty. A TPIT mutation, on the other hand, causes an isolated deficiency of just ACTH, and that leads to dangerously low blood sugar and low cortisol. Then you have NR51, which affects both the gonads and adrenals, often resulting in ambiguous genitalia.
But if there is one genetic factory defect you absolutely have to lock into your memory, it's PIT1. A mutation here knocks out three specific things: growth hormone, prolactin, and thyroid-stimulating hormone. So if you see a child presenting with short stature from low GH, hypothyroidism from low TSH, and then later on down the road an inability to lactate due to low prolactin, yep, their PIT1 gene is offline.
Now, what's really interesting here is how the control room directly above the pituitary, the hypothalamus, can also have factory defects. And these present as these wild syndromic medical mysteries. For instance, if a patient can't smell and never goes through puberty, that inability to smell, or anosmia, points directly to Kelman syndrome. That's a failure of GnRH neurons to migrate properly. What if a patient has extreme obesity, blindness, and extra fingers or toes? That points to Bardet-Biedl syndrome. Uncontrollable eating and low muscle tone? That's Prader-Willi. In all of these cases, the hypothalamus is just failing to send that critical GnRH signal down to the pituitary.
But what if the control room was built perfectly and a disaster strikes later? Well, these are your acquired system crashes. Physical trauma or sudden vascular hemorrhages, like pituitary apoplexy, which is terrifying. It presents with a sudden thunderclap headache and vision loss, can literally just wipe out the gland in an instant. Then there's radiation. Cranial radiation for cancers degrades the system over time. It notoriously knocks out growth hormone first and ACTH last. We also see inflammatory causes, like lymphocytic hypophysitis, which very often strikes postpartum women. And finally, infiltrative diseases like sarcoidosis or tuberculosis. Those uniquely tend to damage the posterior pituitary, causing diabetes insipidus. Which brings us to a truly shocking statistic from the source data: 25 to 40%. That is the percentage of patients who develop delayed pituitary dysfunction months or even years after suffering a traumatic brain injury or a subarachnoid hemorrhage. The physical impact shears that delicate vascular stalk connecting the hypothalamus and the pituitary, and the system just slowly degrades over time. Moving on to Act 2, the alarms. Let's look at the hormonal fallout. Let's start with growth hormone deficiency. In children, the alarm is pretty obvious, right? Growth failure, short stature, delayed bone age. Actually, quick aside, if the body produces GH perfectly fine but the receptors are broken, that's called Laron syndrome, and you have to treat that with IGF-1, not GH. But back to hypopituitarism. In adults, the alarm is silent, and it is deadly. Adult growth hormone deficiency causes an increase in visceral fat and a real drop in muscle mass. The major hidden danger? These patients face a 3 times increased risk of cardiovascular mortality. So the crucial point here is understanding the difference between the actual gland failing and the control room failing. Secondary adrenal insufficiency happens when you have a cortisol deficiency specifically because the pituitary isn't sending out ACTH. The adrenal gland down below is perfectly fine, it's just not getting the signal. Interestingly enough, the most common cause of this in everyday practice isn't a brain tumor, it's the sudden withdrawal of medical steroids, which suppresses the entire axis. The distinction here is incredibly clear. In primary adrenal insufficiency, the adrenal gland itself is broken. Because it can't make aldosterone, potassium spikes. And because the brain is screaming for cortisol by pumping out massive amounts of ACTH, the patient's skin actually darkens. That's hyperpigmentation. But conversely, in secondary adrenal insufficiency, the brain is the problem, so ACTH is low. Therefore, no hyperpigmentation. Most importantly, aldosterone levels are totally normal. Why? Because aldosterone relies on the kidneys and blood pressure, the raw system, not the pituitary. Next up is gonadotropin deficiency, which is for sure the most common presentation of adult hypopituitarism. The diagnosis is confirmed by low LH and FSH alongside low sex steroids. Women experience amenorrhea and infertility, men experience low libido and muscle wasting. The vital takeaway here is the treatment intent. If the goal is simply restoring baseline libido and protecting bone mass, standard testosterone or estrogen works great. But if the patient wants to walk the fertility path, those simply won't work. Fertility requires actually kickstarting the system with HCG, FSH, or pulsatile GnRH pumps. All right, that brings us to our final section, Act 3, troubleshooting and the reboot. The entire diagnostic process really rests on this one fundamental laboratory rule. A low target hormone combined with a low or inappropriately normal pituitary hormone equals hypopituitarism. Think about it. If a patient is exhausted and has low T4 thyroid hormone, a healthy pituitary should be absolutely screaming, pumping out high levels of TSH to compensate. But if the TSH is low or just hanging out at normal, the pituitary has failed to react. That is central hypothyroidism. To truly test the system's reserves, specifically for growth hormone and ACTH, we use the absolute gold standard, the insulin tolerance test. And wow, is this extreme? Doctors deliberately inject insulin to crash the patient's blood glucose down to around 40 milligrams per deciliter. This induces a massive physiological panic in the body, forcing a healthy brain to just dump GH and ACTH to survive. If those levels don't spike, the system is fundamentally broken. Now, because it's so intense, it is absolutely contraindicated, like do not do this for anyone with heart disease, a history of seizures, or advanced age. And this brilliantly illustrates the final, most critical phase, the reboot. If a patient has total system failure, you cannot just throw all the missing hormones at them all at once. There is an absolute non-negotiable sequence. Number 1, glucocorticoids. Number 2, thyroxine. Number 3, sex steroids. Number 4, growth hormone. And finally, desmopressin if needed. Seriously, pay close attention to this quote from the source notes. Never start thyroxine before steroids. If you give a patient thyroid hormone first, it revs up their basal metabolic rate. But if they don't have cortisol, the body's stress hormone, to handle that sudden increased metabolic demand, their system will go into a fatal cardiovascular collapse known as an adrenal crisis. Steroids first, always. Maintaining that steroid replacement, that is a lifelong commitment. Daily maintenance usually means 15 to 25 milligrams of hydrocortisone split throughout the day to mimic the body's natural rhythm. But the most important thing for the patient to understand is the stress dose rule. If they get a fever, need surgery, or get into a car accident, their body literally cannot produce extra cortisol to survive the stress. They must manually increase their dose, which is why carrying a medical alert bracelet is mandatory. And as we learned earlier, because this is a secondary issue, mineralocorticoids are not required. To wrap up, I want to leave you with this thought based on what we've covered today. Given that up to 40% of moderate to severe head injuries can cause delayed pituitary failure, how many adults walking around today with unexplained fatigue, sudden abdominal weight gain, or deep depression are actually suffering from a hidden system crash caused by a forgotten concussion years ago? It really forces us to look at vague patient symptoms through an entirely new systems-based lens. Thanks for joining me on The Explainer today, and keep learning.